Welcome. We'll just start in a couple moments. We'll wait till everybody populates over from the waiting room. Good afternoon, everybody. Good afternoon. Thank you for joining us. We'll just start in just another minute. We'll just allow everybody to populate over from the waiting room. Looks like the majority are coming on over. Okay, good. Awesome. Well, good afternoon, everybody. Thank you for joining us today. My name is Chantel Lincoln, and I serve as the Deputy Director at Drug Free America Foundation. Today's webinar, it's not just weed anymore. What to know and how to help pregnant and postpartum women using cannabis, THC, is supported by the Florida Department of Health and is part of Drug Free America Foundation's Marijuana and Pregnancy Educational Project. Before we get started, there's a couple housekeeping items to take care of. Please take a moment to introduce yourself in the chat box. We'd love to know who joins us today. Put your name, organization, and where you're from. If you have any questions during the presentation, please place them in the Q&A box. That way we can address them towards the end. This session is being recorded. You will receive a follow-up email with a link to the recording, the presentation slides, and a certificate of attendance. At the end of the webinar, a short survey will appear on your screen. We'd greatly appreciate if you could please take a moment to complete. So with that, I want to take a quick moment to talk about a project we're really excited about. It's a photo voice project empowering mothers to build drug-free families. We're currently recruiting Florida-based mothers and mothers-to-be with lived experience of substance use. And that can mean you're in treatment, you're in recovery, you've been impacted in any way by substance use. You could have had a child, a family member pass away from substance use. Also, professionals within the field. The project is aimed to empowering mothers to build drug-free families. So we're currently recruiting. You have to be in Florida, though. You must reside in Florida. And we're providing $100 to anyone who participates and completes the project. If you would like or have anyone interested, please share them on your network. You can scan the QR code on the screen. It'll link you to our dedicated webpage, and there's a sign-up link. So with that, let's get started. It's my pleasure to introduce you today to our esteemed presenter, Dr. Hendrée Jones. Dr. Jones is a licensed psychologist and professor in the Department of Obstetrics and Gynecology at the University of North Carolina at Chapel Hill. She previously served as a division director of UNC Horizons and now acts as a senior advisor, taking on several national and international policy projects. Dr. Jones has received continuous NIH funding since '94 and is recognized globally as a leading expert in neonatal abstinence syndrome and opioid-related disorders. She has authored over 250 peer-reviewed publications, developed 17 professional training courses, and contributed to numerous national and international guidelines, including work with SAMHSA, the United Nations, and the World Health Organization. We're honored to have her with us today. What an impressive resume. Please join me in welcoming Dr. Jones.
Thank you, Chantel. It is such a joy to be with all of you today. I see we have 75 people, which is a terrific turnout. And I love Drug Free America Foundation and was just so thrilled to say, yes, I would love to join in this conversation that we are having about cannabis, high concentration THC, and just to reinforce the idea that it is not just our parents' or grandparents' weed. We have a different conversation to have these days about cannabis and high concentration THC. And so I have no disclosures to share regarding this presentation. And there will be at least 2 points where I'm going to ask you to put an answer in the chat. I'm going to invite you to do that. So just know that those will be coming up to keep it a little interactive. And I hope we have a few minutes for conversation and Q&A. In terms of the objectives that I have that we will cover today, we're going to look at what cannabis is, the THC concentrations, how it's being used right now, how the potency's changed, and the effects both on mom, the fetus, children, and fathers. We're going to be briefly looking at some screenings as well as interventions for cannabis use during pregnancy, and also interspersed within that are ways that you can support patients over all 4 trimesters. And then finally, um, I did that twice. We only had 3 objectives. I'm sorry. Okay, so let's move to the history of cannabis. I'm sure many of you are familiar with this. It is an incredibly ancient plant. It has been used for medicinal purposes for a very, very long time. In the 1800s, it kind of went more mainstream. In the 60s, they were able to identify the THC molecule, delta 9 THC, the one that has been most creates the most psychoactive effects that we know about. Then we understood more about the endocannabinoid receptor system that all of us have in our bodies, and we will talk about what that means. And then we moved into the legalization of medical cannabis, and then recreational cannabis with Colorado in 2013. And that has really changed the landscape of the commercialization of THC products and really what's happening in our country in terms of how many people are using it and what the effects are. So what you can see in this slide is, cannabis THC is a really interesting substance because on the federal level, it is still an illegal substance, but on the states, as we know, have been legalizing or decriminalizing or allowing medical use. And so the landscape, this map is probably out of date already, but just to note that it is so much in flux, and that creates challenges for our healthcare system in terms of how to respond to these substances. So the plant itself is an amazing plant. It contains more than 200 psychoactive substances, but of course the one that gets the most press is our THC. And there are 2 kind of most common types of the cannabis that we're talking about, the sativa and the indica. I'll mention those in just a second, but they cause a variety of psychoactive effects. And the cannabis growers have been doing a lot around genetically modifying the plant, increasing the THC content. And so when we talk about cannabis, it is the entire plant. There could be dried leaves, there could be the flowers of the plant, the stems, and the seeds. So there are different, as I noted, there are different types of plants, and they give you different effects. So this is just to ground us in the reminder that there are different effects. So we've got the sativa with the long, thin leaves. We've got the indica with the broad leaves. They create different things, as you can see on this slide. And then, of course, there's hybrids to kind of bring you up and bring you down. So the sativa is that sort of more energetic kind of psychoactive effects, that creative effect, the euphoria, the sociable, the cheerful. The indica is more of that relaxed, mellow, sleepy. And so some people will use different forms of cannabis depending on how they want to feel, up or down. What's changed drastically in the last couple of years is really how that cannabis plant is being processed and the types of substances. So we've got oils, we've got waxes, we've got bubble hash, we've got these jelly-like substances, we've got butter, we've got shatter. All of these things have incredibly high concentrations of THC, and they can create some real problems for children, for adults, and we're going to talk about pregnancy too. The other piece of the landscape that's also changed is how it's being administered, right? Back in the 60s and the 70s, it was really what we called like the left-handed cigarette. Now there's so many other ways. There are vaporized oils that people can smoke and inhale. There's the bubbling with the water. There's suppositories that you can use. And then there's a whole host of different types of consumable edible products that when you look at these, sometimes you can't even tell the difference between candy and these edibles that are marketed as candy or brownies or sweets. So this is just a chart to show, this is from the DEA, so these are the illegal substances that are being seized, or the illegal amounts that are being seized. And you can see that over time that the concentrations of THC as well as the CBD are, well, particularly the THC is increasing over time. I pulled this from the Washington State website because I thought it was just a really important example of how states are informing publics and responding. And so they remind us that the THC in like Washington is that dried cannabis and the concentrates are shown as percentages. They remind us that the cannabis that was harvested in the 90s was about 5% THC, but now the commercialization of these products is really increasing the concentrations. And so we're seeing 15 to 20%, some 35%. Those interesting different sort of waxes, resins, shatter, that sort of stuff can be up to 90% pure THC. And that I just for our children, I just can't stress enough how incredibly dangerous that can be for them. And then the last thing I wanted to highlight was Washington does not really, because these things are not FDA approved, right? There is not a medicine that we smoke. The sort of standardization, the real quality control, the really what we know about the actual appropriate, accurate labeling of these substances is nil. There really doesn't seem to be much standardization or regulation around these. Um, and I also wanted to put this in. This is from my state of North Carolina, where I am. And we had a farm bill that was introduced in 2018. And after that, it really it opened the door for a lot of different types of THC products to come into our state. And not surprisingly, we are seeing over a 600% increase in THC ingestion for children 17 and under. And we're also seeing emergency department visits go up, as you can see here. You can see the very light blue line is that 15 to 17 years of age. And we're getting almost 50 kids per 100,000 going to the ED with this. So something to definitely pay attention to, and we need to have better regulation and control. So why are we seeing increased acceptance of cannabis and high potency THC use? And let me just also say, I'm going to use cannabis where the literature uses cannabis. So you hear me say that a lot, but sometimes it's not really even the plant anymore. There's so many different types of synthetic THC products, but as sort of a catch-all generic term, I will probably end up defaulting to the word cannabis. So, I think we've always had this sort of idea in our United States that something is legal equals safer, right? We saw this with our medical opioids in the crisis we had there. And we see this with alcohol, right? We know lots about alcohol and its negative effects, and yet still it's fully legal in most places. So we get this sort of false sense of security that legality equals safety. And for our teens, there's a ton of marketing that is happening right now. So there's kind of this assumption that, well, if it's okay for adults to use, it's not, how bad could it be for children and teens? And we're really lacking those good, consistent, evidence-based public health messages that cannabis is not safe for our teens, our developing brains to be exposed to. And then for our OBGYN providers, because we are talking about pregnancy in the postpartum period, a lot of the OBs I talk to just aren't familiar with cannabis during pregnancy. They think that it's still sort of that like the 60s, and they're not up on what's really happening with these commercialization of different products. Cannabis they perceive as less dangerous than other forms of illicit drugs. We heard so much about cocaine and now opioids, but cannabis has gotten less attention overall comparatively. And then finally, there are a number of OBs too that are very concerned about the risks of child protective services and their patients being sort of caught up in that system because of cannabis use. And so I've even had OBs and social work say that they don't even look at a cannabis. Cannabis has been removed, THC has been removed from the urine drug testing or the meconium testing panels because one, it's so common, and two, they don't know how to respond to it. So I want to make sure that we don't want to ignore things. Like when things are a problem, we need to be able to recognize that, identify it, and have compassionate and evidence-based responses. So, and we'll talk about that in a few minutes. And then finally, there's because of all of the advertising that has happened with the commercialization of cannabis, the public now really supports the legalization of cannabis, and maybe without truly understanding all of the nuances of the different forms and the potencies and the potential really negative effects. So I'm not going to touch on CBD. I just wanted to acknowledge that it's there, acknowledge that it's going to be beyond the scope of our talk, and that there are some preclinical studies looking at CBD exposure during pregnancy. We know that this type of substance is not without harm, but we also need to understand more about it, and especially around pregnancy. Okay, so our brain, so as I mentioned before, the endocannabinoid receptor system that we all have as humans, and our brain has a lot of cannabinoid receptors, right? And there's been beautiful brain imaging work and behavioral work that has shown that the endocannabinoid system is part of brain development. We know that the endocannabinoid system is as a part of memory and cognition. It regulates mood and emotion. That means that stress, the anxiety, how we respond to different situations, pain perception, I'm sorry. And it's also responsible for helping to reduce inflammation. We know that the endocannabinoid system is a part of our sleep regulation. And so when it gets disrupted, we either get really sleepy or we don't sleep well. It's part of our immune response. And it can also protect our neurons from dangers, from external dangers. And finally, the other piece we're going to talk briefly about is its role in reproduction and fertility. Other actions that our endocannabinoid system has are insulin sensitivity and secretion, cardiovascular effects. We have relationships between cannabis use and myocardial infarctions. We know the immune system, right? Continuous cannabis use can suppress our immune system. We can have adipose tissue issues, like metabolism issues, GI tract issues, and liver issues too. So, what are some of the acute effects of high concentrations of THC? Obviously, intoxication, which we see kind of the stereotypical bloodshot eyes, right, for which people use Visine for. We can have increased heart rates, but yet decreased blood pressure. We can have delayed motor coordination, which is why it's really dangerous to drive a motor vehicle after people have been using cannabis. They can have slowed reactions to stimuli, hallucinations, paranoia. We're seeing a relationship between high concentration THC and the development of schizophrenia in young people. And then we can also have just decreased cognitive functioning, less attention, less concentration, slower speed of information processing. And with continued regular heavy use, right, we can continue to see that detriment of our cognitive functioning. We've got more car accidents that are happening. We've got higher rates of co-occurring tobacco and other drugs. People can develop this excessive vomiting, this hyperenuresis syndrome, which I'm going to talk about in a little bit, but wanted to highlight that. And of course, that disrupted sleep. That hyperenuresis syndrome can be really frightening and concerning. It can land people in the hospital because they just can't stop having nausea and throwing up. And the only thing that seems to help them are really hot showers. And there's very limited data on this in pregnancy, but I wanted to mention it and we'll still talk about it. So now let's turn to the perinatal period, since I've kind of tried to level set about what cannabis is, what high concentrations of THC are, and we're going to look at aspects of the perinatal period. So first, what is the problem that we are trying to solve? So we can see here from this slide, these are National Household Survey data, the National Survey in Drug Use and Health. And these are data from 2017 in the sort of medium light blue, all the way up to 2023 in the dark blue. What you'll notice, the first thing I want you to notice is that when we talk about pregnancy, the most common substances that are used during pregnancy are tobacco and alcohol, are two most fully legal substances. And that, by and large, has remained pretty stable. It looks like we've done kind of better with tobacco since 2017. And what you'll notice about the illicit substances, if I was to kind of dig down in this and tell you what it was, the vast majority of patients that are responding to this survey are endorsing cannabis use and THC use during pregnancy, which really contributes the vast majority to these lines here. The other thing that I will invite you to notice is that from 21 to 22 and now to 23, we saw sort of a bump in reporting of illicit substance use during pregnancy that kind of maps onto the COVID-19 pandemic. So I gave you the national data. I want to drill down and give just one example of how this kind of plays out. And so these are really lovely data from West Virginia, where they had over 34,000 pregnancies with reports of substance use. And among those pregnancies, the most common use of a substance was tobacco, as we can see here, that nicotine, the smoking. And just like I said for the national data, we see that pattern reflected here. So the most common illicit substance that was reported is our cannabis use, with 7.9% of pregnancies being exposed to that. These are data just to kind of reflect, again, what we saw in the national data. These are data tracking cannabis use during pregnancy, before COVID-19 and then during COVID-19. And you can kind of see that increase during COVID versus before COVID. It's also interesting to think about, what are the drivers? What are women who are pregnant telling us about why they are using cannabis during pregnancy? And so these are data from South Carolina. And what we can see, these are from self-report interviews. And when we look at pre-conception, people are using cannabis. I think 95% of people were reported using cannabis pre-conception and in this sample. And you can see stress, anxiety, pain, having fun to relax, sleep, improve mood, use with partner or friend, and then an increase in appetite or to gain weight pre-conception. During pregnancy, we see that pattern change a little bit, right? So fewer women are using in pregnancy to relieve stress than pre-conception, right? But you can see the main driver for use in pregnancy, the most common or the largest percentage, is to increase appetite or gain weight. Then when we look postpartum, keep going across to the postpartum, that final column on the far right, you can see that the main reasons for use postpartum are to reduce stress and anxiety. So I think it's really interesting for us to understand what patients are telling us in terms of what is driving their use. What is the problem they are trying to solve with their cannabis use? So it's really important to be able to screen, to ask those questions. And we know from our American College of Obstetrics and Gynecology that we want to screen everybody to understand what are the risks, not just cannabis use, but all sorts of different types of risks. Because when we understand what is happening, then we can have a response. And so we really want to start screening, ideally at the first prenatal visit and then throughout pregnancy. And the screening, the idea behind it is to start a conversation, to be able to share information, have a shared decision-making approach. So some considerations in that universal screening: we want to use a valid verbal tool, not rely on biological measures, but to be able to have that conversation. And when we can screen, we can reduce those potential harms. Pregnancy, as we saw, can be a time when many patients are excited and motivated to make a change. Not everybody, but many patients are. There's also other risks. Risks for screening are that we're going to increase the stigmatization. So that means that our patients aren't going to come back to us. We could also put our patients at risk for legal charges or losing custody or parental rights. So how we do the screening, how we document the answers to the screening, what we do with that information, and how we chart it, how we inform other people with the patient's permission is all very important aspects to screening. So we have this great opportunity to use non-judgmental language, to have a compassionate attitude. It doesn't mean that we're necessarily condoning the patient's behavior, but we are accepting the patient as the person so that we can help them make the needed behavioral modifications to improve their health, their fetus's health, and the health of their family. So I want to make sure everybody is aware of this. There is a new validated screening tool specific for cannabis in pregnancy. There's 9 items, although I will say that that ninth item, which is not represented here, has a number of letters behind it. So it's really more than 9 items, but they call it 9 items. It has excellent validity. And it's also the thing I really like about this screening is that it holds up. It is able to determine with self-report as well as those just doing urine drug testing. So this allows for a conversation and allows to understand more in a more nuanced way what's happening in the patient's life with cannabis. So let's say now that a patient has said, yeah, I'm using cannabis to relax every day. It's the only thing that helps me sleep. It's the only thing that helps me gain weight, right? So we want to understand what is that role that cannabis is playing in their life. And I just gave you some of those answers. We want to start screening, ideally at preconception, right? If we can build this in as part of the conversation with all sorts of other health behaviors like sleep, like nutrition, like exercise, like all those things, we can better understand, have better rapport, be able to better intervene. And unfortunately, patients, at least in the literature that we have, patients report very few people giving them concrete information about prenatal exposure to cannabis or high concentrations of THC. And this is a quote that says, the only thing they're telling me about marijuana is just don't do it. They're not telling me don't do it because this could happen or that could happen, or your baby could have this. And right now, I don't feel like they're really concerned. So that quote should be a really important reminder to us that we need to be specific with the information that we are providing, tailored to um, what's going on in that patient's life. Okay, I've talked a lot, so this is your opportunity to put into the chat what are some of the reasons that you all might think or maybe even have experienced as to why providers, that could be social workers, medical doctors, obstetricians, included in medical doctors, PAs, might be reluctant to screen or counsel patients about cannabis use in pregnancy. So I'm going to give you all a moment to write in the chat, and I will be looking at it. All right, they might feel that they're going to use cannabis anyway, so why bother, right? Due to the prevalence of use, yep, feels like everybody's doing it. They're pro-use, absolutely. Reluctance to make an abuse report to the idea of harm reduction, then they become higher risk, right? And so they might lose their patients because Child Protective Services can become involved and they might lose the client. Yep, so fear of DFS. It opens a big door to a lot of questions, right? And there we've got time constraints, right? And maybe not fully aware of the risk. Excellent. Thank you all. Yes, all of those things are very important barriers. And also, I like to see barriers as opportunities for changing the way we have conversations, being creative about what we do. There's opportunities, for example, to partner with Child Protective Services so that we can give accurate information, transparent information to our patients. So let's talk a little bit right now about what are the actual risks that we know from evidence-based uh, data that we have. So I want to give a shout out to Kelly Young-Wolf, who's been doing a lot of work in this area and has very large data sets that she has been using. And these are some of the outcomes that she has found. A lot of times, our research will really focus on the baby. And so what I think is what I wanted to highlight with this particular study is that this is really mom focused. So what Kelly was able to find in this study was that prenatal cannabis use was dose dependent. And I think this is an important part. Certainly, we have not every single person that is using cannabis has a designated diagnosis of a cannabis use disorder. We also know that when people are continuing to use substances, our moms are continuing to use substances like alcohol or tobacco or cannabis during pregnancy, that is putting themselves at risk. And so that would at least be one of the complete 11 DSM potential criteria for having a diagnosis of a use disorder. So here are the outcomes that we have. So more cannabis use puts us at greater risk of gestational hypertension, preeclampsia, gaining either less weight or more weight than our guidelines are telling us is good for our pregnant moms. And then finally, placental abruption is also at increased risk. And the other interesting thing I thought was that, again, they were finding these results both by self-report and by urine toxicology testing. So I think it's kind of like another sort of plus for self-report. So this is the most recent systematic review and meta-analysis that I was able to find. And I will say that this literature is rapidly evolving. I mean, literally, probably by the time I put these slides together, it's already out of date because there's just a wealth of information that's coming out, which is really important, which is really great because now people are paying attention to this. So what we see in this study here is, hang on just a second, because I need to minimize myself, so these are a number of different studies they looked across. And so we see preterm birth as having a greater risk for preterm birth with identified cannabis exposure. We have greater risk for perinatal mortality and greater risk for gestational age. What I will tell you is kind of did not come out very clearly in this meta-analysis and systematic review was the effect on birth weight, right? And so that's actually why I put into this graph a reminder of the adjustments that they made. So when we have data, we have lots of different variables, and there can be lots of different variables that are contributing to the outcome. And so I just wanted to remind us there that it looks like when these other types of variables are controlled for some, we're not seeing a very clear relationship between reduced birth weight and cannabis exposure. That said, and this is what makes this literature so messy, is the idea is another systematic review that was done. They looked at 932 studies and found that prenatal cannabis use appears to be associated with lower birth weight, right? So one study says not necessarily conclusive. The other study says yes. Preterm birth weight and neonatal intensive care unit admission. The other piece to point out is that there was little evidence that prenatal cannabis exposure adversely impacts the behavior or cognitive outcomes of children in early childhood, with the exception of attention and externalizing problems. So again, our research is always changing. So we have the other piece to keep in mind is that there are these synergistic effects of tobacco and cannabis, and this paper really just kind of highlights that we know that neither one of these substances is going to produce positive outcomes for our pregnant moms and babies, but also that together they can create a risk for more complicated outcomes, as we can see here. All right. Now let's turn for a moment to the longer term outcomes. And so I also really importantly want to highlight that the best longitudinal data that we have regarding the relationship between prenatal cannabis exposure and long-term developmental outcomes, those studies started in the 70s, right? In the early 80s. And we know just from, if you'll remember from the beginning of our talk, that the concentration in THC is so much greater now than it was then. So the extent to which these data are still generalizable for our current context is a bit unknown. So, but you can definitely see even then that it seemed like at birth there really weren't any differences between the comparison samples, but yet as children got older, and I know the Ottawa study in particular noted cognitive executive functioning being less in our prenatally exposed cannabis kids than in comparison kids, for an example. And so this is just a nice little schematic drawing of what they have found, again, keeping in mind that those were the somewhat earlier data, the earlier studies. And hopefully we will have more with the National Institute of Health ongoing longitudinal study of adolescents that's happening, as well as the HBCD study that's looking at pregnancy prospectively. I believe it's up to like age 5 postnatally. So yeah, so you can just see here the different changes that were identified, and I'd already mentioned that one about the cognitive functioning. So other things, yes. So we just have, the any studies that are done looking at longitudinal outcomes are really difficult studies to do. We have to look at all the other types of contributing factors like prenatal exposure to co-occurring alcohol, tobacco, other drugs, and it's hard to measure the quantity as well as the potency of cannabis is not known. So what are the dose effects? We also need to control for other types of environmental facts, such as the children growing up in a home where maybe other types of substances are being used, or violence is happening in the home, or they have a high socioeconomic status or versus a low socioeconomic status, or their nutritional status. So I could give you a whole talk on co-occurring concomitant variables that we need to control for. So I think the bottom line is that we need to screen our children, we need to assess our children, and we need to provide early intervention services so that whatever issues that are identified, we can get on top of very quickly with parental help and support to make those changes. I also want to make sure that everyone is aware of the really interesting data that are also coming out around paternal cannabis use. So we are seeing mostly these are preclinical data, so these are animal data, but they have been able to show in pretty refined studies that paternal cannabis exposure can alter brain development in children, particularly in areas with learning, memory, reward, and mood, right? Remember that endocannabinoid system. Um, and the interesting thing about that is that these changes are seen in human babies exposed or similar to those exposed to neurotoxins like pesticides or tobacco. Sperm quality can also be reduced when our fathers are using cannabis, right? And so that can produce a reduction in fertility as well as motility of the sperm. Miscarriage and other birth outcomes can also happen. It's been related to paternal cannabis use, as well as epigenetics, which is this really innovative and dynamic field where we're looking at how the environment can turn genes on and off and create different health issues and even different behavioral issues. So stay tuned for more information about this, but I wanted to highlight that because I think this is important for families to know as they're coming in for prenatal care. What is the role of the father if they're having preconception counseling, right? This can be something really important to also think about. So, what might explain the continued use by pregnant women of cannabis during pregnancy? So, there are different ideas, right? Maybe women don't understand. Maybe they don't believe the risks. Maybe they do understand that there are risks, but they just aren't able to quit. And that would be indicative of a cannabis use disorder, that could right there. Maybe women understand the risks, but choose not to quit because they feel in their own personal life that the benefits of continuing the use, that maybe they're getting their alleviation of anxiety, they're able to sleep better, they're able to gain weight, and those things are more important to them. We also have this very gray area of medical marijuana use. And I think, as we think about this, there are no other substances, no other FDA approved drugs, or no FDA approved drugs that are smoked, right? So I think this idea of medical marijuana use can be really tricky for patients to understand. So these are data to show, these are National Survey of Drug Use and Health data that looked at the role that cannabis is playing in non-pregnant women and pregnant women's lives. And so what you can see for our non-pregnant women who are reporting past month cannabis use, that past year medical use was 7.5% for the non-pregnant women, compared to pregnant women, we're saying that it was 14.06%. Cannabis use disorder also went up. It was more recognized in our pregnant women. And then the need for self-reported treatment also increased. So I think that is good news that patients are becoming pregnant, aware of their pregnancy, and more likely to seek help. This is just to remind us of the DSM-5 criteria for cannabis use disorder. And that there's 11 signs to determine it, and to also remind us that there are evidence-based treatments for cannabis use disorder. Cognitive behavioral therapy works for not just cannabis use, but all sorts of other psychoactive substances for which people have problems. And then our motivational enhancement therapy is also an effective intervention. What about nausea and vomiting, right? We hear a lot from our pregnant patients just saying, I'm really struggling with nausea, I'm struggling with vomiting. My marijuana, my cannabis makes me feel better. And so these are data just to show marijuana use among females undergoing screening for their first trimester in pregnancy. And so you can see that the none versus mild versus severe is decreasing, right? We can also see that 81.3% of medical marijuana dispensaries also recommend cannabis for use in morning sickness, right? And I don't really know where the evidence is to support that. So that evidence seems to be self-reported. So we know that this is not necessarily the best information to give our patients. What about cannabis hyperemesis syndrome? So this is an example of how to define it, and it's when the symptoms have been present for the past 3 months, right? They've got stereotypical episodes that are lasting more than a week as examples, or no vomiting between episodes, and the milder symptoms can be present. So this is just a way to remind us, if we have patients that might be struggling with that there is a tool to be able to define it. And so once we have identified that somebody is struggling with cannabis, it's interfering with their life and their roles, their responsibilities, it's endangering their health, we want to understand how to intervene. And we really want to start by talking with our patient and identifying, why do you what's making you like using this substance? Tell me what you like about it. Tell me what you don't like about it, right? What are some ways that it might be interfering with your ability to be the person you want to be, to have the pregnancy you want to have? We want to give some information, but ask permission before. Is it okay if I review some of the health risks that we know from our research to be there? And don't assume also that our patients know everything, right? So ask them what they know. Hey, tell me what you know about the risks of cannabis use during pregnancy. What have you heard? That can be really enlightening and helpful to have those conversations. And you can also understand who it is that they're giving them this information, where are their information sources. And maybe you can take a look at those and potentially counteract some of those if they're not accurate sources for information. We want to be able to enhance their motivation for change. We want to be able to give some advice and negotiate goals. And the most important thing is setting up a follow-up, right? We want our patients to come back to us, or the people that we are serving to come back to us, so we can continue to have conversations, continue to have opportunities to intervene in their behavior. And why do we need to be concerned about cannabis use during pregnancy and breastfeeding? If you remember when we started this talk, the endocannabinoid system, right? It is just essential in embryo fetal baby development. So it's regulating mood and anxiety and emotion. It's related to pain perception. It reduces inflammation. It regulates hunger and metabolism. It regulates sleep. It regulates the immune response, memory, learning, and protecting our neurons from damage, and then future reproduction. So this is an incredibly important system to help support and nourish. So oftentimes the focus is so much on the pregnancy. And what I like to say is, our moms go in, they have a life-changing event, they deliver this baby, and then often our medical system, the way it's set up, will say, oh, well, we'll see you in 6 to 8 weeks, bye. Don't forget to make that postpartum appointment on the way out. And that isn't necessarily the best, most helpful and supportive and healthy way to address postpartum. We know that our moms can be at great risk for postpartum depression, for return to substance use if they have not been using substances during pregnancy. We know there's incredible changes that happen to the mom's body, right, to manage postpartum pain. And remember, those women in that survey in South Carolina said pain was one of the reasons that they were using cannabis to reduce that pain, right, reduce inflammation. They're coping with physical changes. They're trying to bond with their child. They've got all these new roles and responsibilities. So we want to make sure in the postpartum period that we have good contact with our moms. We're evaluating our babies. helping them get off on their best foot forward, enhancing that dyadic relationship. And one of those ways can be breastfeeding. And breastfeeding, in the context of cannabis use, can be a really tricky thing to navigate. Let's just talk first about what are the benefits of breastfeeding that we want to make sure that our moms have and our dads know about to help support our moms. So there's decreased mortality in the first 6 months of life if our moms are breastfeeding. There's reduced rates in children of diabetes and GI illnesses and ear infections. We know that for the mom, right, breastfeeding can lower breast cancer rates, ovarian cancer rates, hypertension. We've got releases of oxytocin, which is that bonding hormone. We know that the WHO, the World Health Organization, also recommends breastfeeding, as does our American Academy of Pediatrics. We know that the breast milk is the best nutrition we can give our babies. And so any way that we can support our patients in stopping cannabis use during pregnancies, continuing to have cessation after pregnancy, because we know that that breast milk is highly lipophilic, right? There's lots of fats in there. And what does THC love? THC loves to bind to fat. So we have, unfortunately, very little data looking at the concentrations of THC in breast milk. We do know that it's there, but there's so few studies. It's really an emerging and dynamic field of study. So the conclusion from this very tiny amount of data that we have is that THC can accumulate in breast milk and that the infant can absorb and metabolize it after ingestion. And so these are just some more of those data that we can see, just some more updated data from 2021. So the bottom line with that is we really don't know, but we need more answers. And regarding neurodevelopmental outcomes, there's even less data than even breast milk data. So we do know that it stays around, and we don't know what the outcomes are. So these are some recommendations in the absence of evidence to guide us. This is the Breastfeeding Medicine has published breastfeeding guidelines. You can use that QR to see that. And what they had recommended is cessation and a reduction of cannabis during breastfeeding. So this is the last slide that I have, so we have time for questions and conversation. So we have clinical pearls for your help, right? So one of the things that we know is when we take a very punitive, hard approach to pregnant women, they are not going to come to us. They are going to remove themselves from care. They're not going to seek care. They're going to wait to the last minute. And then that it doesn't set anybody up for good birth outcomes. And so to the extent that we can, we want to have very transparent conversations with our patients about what are our laws and regulations, our hospital policies around cannabis use during pregnancy. And we also want to be open and curious, right? We want to understand where our patients are coming from, what is the role that the cannabis is playing in their life, and then have ready objective information to share with them, because maybe they really don't know. They need that education. They need to think about this in a different way. Understanding what the role is in their life, making sure that we're having a dialogue, not that we're necessarily condoning their behavior of using cannabis during pregnancy, but we want to be there to support them, to help make healthy choices for themselves, their babies, and their families. We want to learn what helps them. We want to give them some information. We want to ask permission to give them that information. We want to also acknowledge their patient perspective, right? I understand this is really hard. This can be really scary to make those life changes. And I can also understand why you might think cannabis is natural and natural equals safe, because that's what we've been hearing from our media. But let me give you additional information to make you think about things perhaps differently or ask questions. So we want to provide education and recommend reduction in quitting, and recognize that we might not even be able to change somebody's mind, but we can raise doubts, right? We want to plant those seeds of doubt, because when we can do that and have them think that they're not as convinced as they were that cannabis is safe, then we can have a conversation around behavior change. And also, please don't underestimate the power of the cannabis retailer for giving information. Often both men and women are trusting their cannabis retailer for giving them accurate information, and that might not actually be the case. And so with that, I am going to stop, and we have about 10 minutes for questions. I also want to remind you, you are not alone. We are all struggling with how to best respond and support and promote healthy outcomes in our moms, our babies, and our families. And so I'm so glad that we are all learning together. I'm so glad that we have these forums and webinars that we can learn and exchange information and ideas. And with that, I'm going to stop sharing and glad to answer questions. Thank you so much.
Thank you so much, Dr. Jones. Let's go ahead and move into the question and answer period. I see some in the chat box, so let me just pull up the first one. Okay, what about heart defects and brain disorders when babies whose moms smoke during pregnancy?
So I'm not sure I'm not quite sure how to answer that in terms of in as a question. I don't see it in there. So I mean, I would say, right, that what we know from literature is that we have generalized data, right, to suggest, particularly with tobacco use for sure, right? That's the tobacco use and alcohol use are the ones that we know the most conclusive information about. And we know that alcohol in particular, we have very good consistent research looking at physical abnormalities that can occur, particularly in older women who have been consuming heavy amounts of alcohol for a long period of time. I think the other pieces around risks for birth defects and other things, it's hard to study because those are very rare occurrences. And so we have to make sure in the literature we're looking at the relative risk and the absolute risk for the population. And I would say that these are things that we, you know, want to pay attention to, that they are important. And as we find out more information, we will continue to share that information so that everybody has that. And I think the other piece too is looking at a lot of times our parents or moms don't know when they become pregnant and they're not aware that they're pregnant, and so they don't start making changes until after pregnancy awareness. And so anything that we can do prenatally to have better healthy outcomes, as now as we're learning about the fathers too, right? So preconception counseling, preconception care is more important now than ever.
The next one is the vast majority of pregnant women in our areas use marijuana during pregnancy for nausea treatment. How can our home visitors address them with the fact that OB providers are saying it's okay for pregnant women to use marijuana for nausea?
Yeah, so it's so interesting. I've been hearing more and more that OBs are saying, "Oh, it's completely fine to use," and actually recommending it. And that there are so many other nausea medications that are out there. There are behavioral interventions for nausea. I think this is just really highlighting the urgency of the opportunity to educate our OB providers. So I would say when you were hearing that, I would take it upon myself. When I hear that, I go and I give information to the OBs. I ask to meet with them. I ask to get in front of the OB Medical Society in the state, in the individual practice. Let's have this conversation because, a lot of us who are in the drug prevention, drug treatment, recovery field, we know this information, but other people just don't. So we have an imperative to get it out there to the larger population. So I think ACOG is a really important place. There are chapters of ACOG in most of the states, I think. So I think this is an opportunity, and maybe Drug Free America Foundation would want to do something specifically targeting OBs to get that accurate information out.
Yeah, we developed a virtual course on marijuana. It's supposed to reduce marijuana, to help you understand to reduce marijuana during pregnancy. But really, the course is, I mean, that's towards the end of the course and it can take about an hour. So it's very short.
Yeah.
But the majority is about marijuana, what it is, the history, the potency, the diversity of products to get that education out. So if there's anybody on this call that has that access to providers, I mean, it's a free course. I can provide that information and I'll put it in the link in the follow-up email. But that is something that we hear is how do we get to these providers? How can they get that? So we developed this educational course. We have that and it's free. So if you want to
Mhm.
help spread the word to anyone on the call.
A-
Um,
And
uh,
when I just think that there's a lot to actually going to the OB office,
mhm,
and asking for a meeting and sharing the information, because I think sometimes, OBs are so busy, their courses,
right.
like it's really hard. So that like proactive knocking on doors, like we've done that. We did that in Maryland.
Yeah, absolutely. Thank you. And then a similar comment to the previous question is states, one argument I hear is that if we had to choose between society-wide use of alcohol versus marijuana, that marijuana could be safer overall for society. How can we approach this argument?
Oh my goodness. Yes, I hear that too. Right. And yeah, what we know, what we see is that, and so I'm not going to give you like the end all be all answer. I think, we have so much data right now to counteract that argument. Look at our emergency department visits for our children. Look at our driving vehicle accidents. Look at what is, like what is happening, the psychosis rates that are going up. So I think, in part that data came from much earlier, lower concentrations of THC, perhaps. So I think we need to use the data that we have. We need to gather it. We need to make some very simple infographics and counteract with facts.
Absolutely. Um, there in the Q&A box. Okay, this isn't a question, it's just like more of a comment. It says medical doctors do not want to report to child protection.
Yeah, I hear that a lot, and so right. And every state is different, with the laws that they have. I think that there is an opportunity to, one of the things that we've done at Horizons is really partner with our child protective services to demystify what child protective services is. And that is demystifying on child protective services front what the medical providers are doing and our behavioral health and our treatment folks are doing, and also the reverse, right? So sometimes we hear that, child protective services is the worst, and our patients get that fear, and they have living experience of knowing that, somebody had a baby and the baby was they were reported and the baby was removed. And so what can we do to have to bring together all the different players? I know that, we will tell patients that, like, these are our rules and our responsibilities. What you tell us, we're going to need to report. And these are the services and supports that Child Protective Services can provide you. The other thing that we have done is we have meetings all together. So if a report is done, uh, we don't do it without the patient being there. So we will say, these are the concerns that we need to report. You, as the mom, are welcome to be in the call, as a part of the call and a part of the process with us, so that you hear everything that is being said on both sides. And Child Protective Services should welcome that. If they don't, then things are happening in a non-transparent way, and that can set the occasion for a different conversation. But having the mother be a part of that process, she might choose not to be, but giving her that option so that she can see what's being said and what the supports are, and then also helping as a provider be kind of demystify and make it more tangible what the steps are of, if there is a referral that's made, if a case is open, what are the exact steps that the parents need to do to get that case closed, to have that reunification.
Absolutely, yes, very important is transparency. Another comment, thank you so much for the talk, is what we are seeing with societal risk of cannabis mimicking what has seen with legalization of alcohol, such as ER visits, motor vehicle accidents, pediatric ingestions, etc.
Right. Yeah. I mean, I think that it would be hard to argue, I'm sure someone would, but it would be hard to argue that the more fully legal a substance is, the more accessible it is, that, we get less harm. So.
Right. Absolutely. And the next one is, what strategies would you use to support a pregnant client in gradually reducing and eventually discontinuing marijuana use during pregnancy?
That could be a whole nother talk. So one of the things that can be really helpful is a timeline follow back approach where we're going to write out, we want to know about her day, right? So we're going to talk about, walk me through your day. When's the first time you smoke, or what's the first time you use cannabis, right? And let's look at what's happening, right? You're eating breakfast, and it's kind of detailed. Like you get up, you brush your teeth, you smoke before you brush your teeth, like those sorts of things. So we can understand that pattern that's happening with cannabis use. And then we can talk about which place, if you were going to reduce, if you were just going to not use it this one time, which time would you want to do? And then we'll talk about that and how to make that happen. And then it's an ongoing, it's not quick, but it is an ongoing effective process. The other thing we do is we actually graph it. And so we will put what's her goal, right? What's her reduction goal? What's her cessation goal, ideally? And then we're going to graph it with her. You can use an app to do that. There's some really awesome contingency management protocols that are out there that could potentially be used for cannabis. So I think those types of interventions, understanding where the easiest one is to give up, let's focus on that. Let's get that behavior going. And then we're going to turn to the next one. I was successful in doing that with tobacco, with cigarettes in pregnancy. We've got that paper published. I'm glad to send it to you. And just on a clinical basis, that's one of the things that we've done that's worked well.
Awesome. Yeah, if you could share that with me, and then what I'll do is I'll put that in the follow-up email as a tool for our attendees today. And
And
I,
it is tobacco. It's not cannabis, but you can apply it to
yeah,
cannabis.
they can, yeah, they're both kind of go together. There's a lot of co-use between the two, so I think that would be beneficial for our attendees. Well, I see it's 1 o'clock right now, and I don't want to take anybody else's time. So I thank you so much for everybody joining us today, and especially thank you for Dr. Jones for taking the time to come and have this important conversation, shedding light on the evolving science around marijuana use, the growing potency, the critical impacts on maternal and child health, and including the often overlooked paternal use, and then also really stressing that fourth trimester, which is often overlooked and so critical to address and not forget about the patients afterwards. Thank you again for everybody. We will send a follow-up link with today's presentation, recording, and certificate of attendance. And I hope everybody enjoys the rest of their day. Thank you.
Thank you so much. Thanks, Chantel. Chantel, I'm going to send you just a slightly updated PDF version because I
Okay.
noticed two things I wanted to correct. So,
Yeah, no
okay.
problem. Completely
Thank you.
understand.
Thank you so much.
Thank you. Have a
Bye-bye.
great day.
Thanks, everybody.